I'm very pleased to present Dr. Tom Arnold, who is going to talk about scleral lenses fitting keratoconus and other ectasias. Dr. Arnold is a graduate of the University of Houston College of Optometry. During his training, he participated in vision outreach programs in Mexico, Guatemala, and with the Bureau of the Indian Health Service. Dr. Arnold spent 2 years as a research assistant for the early treatment diabetic retinopathy study at the University of Texas Medical School in Houston. Dr. Arnold is passionate about scleral contact lenses and their ability to help patients struggling with compromised vision related to the cornea. He is a fellow of the Scleral Lens Education Society and an associate member of the International Society of Contact Lens Specialists. Dr. Arnold, along with Dr. Melissa Barnett, are co-chairs of the International Congress of Scleral Contacts, the first meeting in the world dedicated solely to scleral contact lenses. He's also a candidate for Academy Fellowship. Welcome, Dr. Arnold, and it's all yours.
Thank you so much. I appreciate it. Okay, good. Looks like we're good to go. Well, thank you for having me, Helen. I'm certainly honored to be here. And when I first went to college, I wanted to be an English teacher. So I've always been passionate about teaching and students and education. So I appreciate this opportunity. A little history about this, about scleral lenses, and that is I graduated a number of years ago. 36 to be exact. And so scleral lenses, their history goes way back to the 1880s. They were the first lenses, and they've gone through several iterations, in the 19th century, 20th century. But now they become only popular in the last 15 years or so. There were some pioneers in the 80s that started working with gas permeable materials that made it feasible to fit scleral lenses because the materials, of course, were breathable. But it's really only in the last, since 2005, 2008, that they've really come into the forefront. So a lot of you, I know, in your student career probably have been exposed to them, maybe have even been fitting them, but old dogs like me had to learn it, kind of on the fly as we went. And it really invigorated my practice. It's taken me around the world. And there's a saying in the scleral lens circles that scleral lenses really do change lives. And they really do. That's not exaggeration. That's not hyperbole for a lot of these patients. It's a difference between seeing and not seeing, working and not working. So I hope to give you a little, awaken some of that passion. These are some of the people I hang out with and learn from. So, when we think of keratoconus, we pretty much probably think of scleral lenses in terms of keratoconus, and that indeed is probably the most common indication for it. And so I'll take you through a typical case that maybe you've encountered in your training, certainly will encounter as you get into practice. So a 39-year-old male. He was diagnosed quite late, as a lot of these patients are, because people just don't have the awareness or the technology. He's a salesman. He was referred, I'm outside of Houston, Texas, and an OD in Beaumont, Texas, which is about 120 miles away, recognized the needs of this patient and referred him to us. He'd been wearing soft contacts for a number of years. And his chief complaint was he hadn't seen well in years, and he wanted proper contacts, to use his words. And so all of us have access to topography. So here's his topography. And a couple of things I want to point out here. First of all, a lot of these people who are severe can't wear glasses. You can see his manifest there. That's not feasible. So contacts really are this gentleman's only option. The other point I want to make is about the topographies itself. These are axial maps or sagittal maps. And look at the OD eye, and you can see what appeared to be a central cone. And you can look in the left eye and see that it's a much larger cone, an inferior oval cone, which is very, very common. And I just want you to, another thing about axial or tangential maps is the color scheme, and we're going to talk about this more in a minute. You're all familiar with the more red it is, the more elevated, the hotter it is, the more ectatic it is. But that that's not elevation, okay? That's not the shape of the cornea. That is the power change, and that's an important point. So anyway, look at his manifest RX. So why is the vision poor in the right eye? Well, isn't the left eye worse? Doesn't the left eye look worse to most of us? I think most of us would say that. But here's the trick, especially with scleral lenses and especially with ectasias. I want you to get used to thinking about elevation, all right? Elevation is the difference or the discrepancy between the patient's cornea and a best fit sphere. And the color scheme is different, and that's what I want to point out to you. In elevation maps, the blue, the purple, blue, those are the more ectatic regions. Those are regions that are below the best fit sphere. So the red is not, the red is above the sphere, more elevated. The blue, purple is below. And so you can see here, let me see if you can get rid of this little picture here. Yeah, good. And the other thing I want you to think about, and we get this from rigid lenses, is I want you to think about the best fit sphere, radius of curvature. If you look here, I hope you can see my mouse, 6.6, 6.59, the back surface, 5.9, 7.3. So you can see that this best fit sphere is flatter, not as steep as this. That's one clue, and also the back surface. So one rule of thumb I want everybody to understand, 7.5 millimeters is 45 diopters. I want you to memorize that. 7.5 millimeters is 45 diopters. And that's a good thing just to keep in mind as a reference base. So when we look at the K max, you can see that the right eye is certainly more ectatic. It also is thinner, by about a little over 30 microns. So it is the more ectatic region, all right? But what drives this case is elevation, okay? And that's what I want to kind of focus on here. All right, elevate yourself, all right? You have front surface curvature, you have back surface curvature. In keratoconus, it's generally acknowledged that the curvature changes, the ectasia occurs on the back surface, all right? And so it's possible to have a fairly symmetrical or smooth anterior surface, but a very asymmetrical ectatic back surface. And this is why a lot of these patients are not picked up earlier when you're using general topography, okay? So think of the elevation, get comfortable with what's higher than the best fit sphere, what's lower. And another tip here, again, you can see, if you look at the two eyes, again, you can see that this elevation is a lot greater. The cone really pops out here in the right eye, as opposed to this more global cone that we had on the left. But when the location of the front and back areas of maximum ectasia, when they're lined up, okay, when they're congruous, let's say, then you have a pretty good chance of functional vision, all right? So as bad as this guy is, we can think that if we can mitigate this degree of ectasia with a scleral lens, he ought to be able to see pretty well. And that's not the case here. This is another gentleman, a different case, a lot more ectatic. You can see the irregularity. And this is keratoconus. This is an extreme case of keratoconus. And the front elevations and back elevations don't line up. You can see that his back elevation is a lot more ectatic. So in cases like this, you don't want to overpromise. It's an old salesman's thing, underpromise and overdeliver. So in some cases, scleral lenses don't give you better acuity than you'd get with a well-fit corneal lens or a hybrid lens. This is the same patient, not the patient from Beaumont, but the patient that you just saw with his Pentacam, and most of you in school now probably have been exposed to this. A Pentacam or a Galilei or a OrbScan, some sort of Scheimpflug camera, takes 25 slices. Here's the little camera icon. Here's the slice. This is what we're looking at. So you can see that here's the center of his pupil, but the thinnest point is way out here. The center of his cornea is offset. So this is where in Scheimpflug images, and this is scarring. So you can see the gentleman's quite severe. But let's go back to the guy from Beaumont. And we actually had fit him in 2019, and he was doing very well. But lately he came in for his annual exam, said the left lens had been bothering him. It wasn't quite as comfortable. These are the sagittal values. It was a 16 millimeter lens, which is a very typical diameter, kind of an average diameter. You know, these are toric. He has a toric haptic, about 200 microns of toricity, and we're going to talk about that in a minute. I do want to point out something. We're going to talk about sagittal depth, and that is of these particular lenses. And that relates only to whatever brand you're working with. There's a lot of factors that go into what is the sagittal depth that any particular manufacturer indicates for their lens. And again, we'll talk a little bit about that. So here are my little notes. You know, his right eye looked good, but his left eye didn't look so good. It was twisting a little bit, and it was my notes, my typical handwriting. Lens is low, and I'm going to increase the toricity to do that. Okay. So, you know, my picture kind of verifies what I was jotting down. He has some impingement here. And I want to say that on your follow-up visits, or in this case, his annual visit, you want them wearing the lens at least 4 hours, 4 to 6 hours. You don't want to have these visits first thing in the morning, because lenses settle. You know, lenses settle over time. So you want to see him after the lens has been in the eye, you know, for some time. But actually, I'm not too bad an artist, I don't think, because I'm indicating here in my little drawing that indeed he does have a lot of abrasion here, and he has this little imprint here. But the other thing I was going to say is that you always want to take the lens off. You want to take it off yourself so you can feel the amount of suction there. Is it easy to take off? You know, does it come out readily? You want to feel that tactically for yourself. And then you also want to stain, and you want to look for areas of staining, especially in the limbal area. So I would urge you all to do that. And sometimes you'll get rebound. I will want to say, sometimes you'll get a nice white eye. You'll look at it and the eye's white. You take the lens off and boom, it'll just turn red in a matter of just a minute or so. And again, that's compression. So you want to look at that. Okay, well, why did my lens fit well last year and now it doesn't fit? You know, what did I do wrong? Well, everybody, you're fourth years now, but I assume way back in first year, you probably had ocular anatomy. And you might have run across something called the spiral of Talot. And that's just the observation, the anatomical observation that the recti, the major recti, insert at different distances from the limbus. And they do that in a clockwise fashion, starting with the nasal aspect, going around clockwise. And that's known as the spiral of Talot. And that affects our fitting quite a bit, as it turns out. Greg Denier and team, I'm going to pull up the reference in a minute, but Dr. Denier from Ohio and his team surveyed 140 scleral lens patients, and they mapped their sclera, right? And they said, well, how many of these patients are spherical? How many are toric regular, meaning what you'd think of as normally against the rule or with the rule? That is, it's steeper vertically or steeper horizontally. You know? How many are asymmetric, that is high or low points. That means maybe they're so-called with the rule, maybe they're steeper vertically, but the amount of steepness in the superior versus inferior is different, maybe as much as 200 or 300 microns. That's asymmetric high or low points. And then periodicity, different from 180, simply means the two steepest points are not in a meridian. They're not vertical or horizontal. They may be next to each other. They may be superior nasal or inferior temporal, something like that. So they're not symmetrical. And if you do the math, it's 2/3 of your patients. You know, 2/3 of your patients are not symmetrical at all. So it's no wonder why one of the biggest challenges in fitting scleral lenses, and what you need to be proficient at, and we all do, is centering the lens. Okay, and that is a very big challenge. So if you haven't read this paper before you graduate, I urge you to read it. It's almost 3 years old now, and it's a very, very good paper that lays out all this data. And it really woke up a lot of our community that how much toricity there really is there and why it's such a challenge to center the lens. Okay, so how am I going to fix this guy? Okay, well, a number of lens manufacturers have their own online calculators to help you, through this process. So I used one for this particular lens. So what you do in this particular calculator is you put the lens in the row A here. That's the lens he's wearing. And you saw that I was impinging on the limbus a little bit and the lens was dropping. So I'm going to give him an extra 50 microns to make sure I get over that superior limbus. And I'm going to increase the toricity about 75 microns, which is really quite tepid. That's not a lot at all. I don't know why. I could have easily increased it by 100 or so. But the guy was basically okay like he was. So I was hesitant to make, huge changes. So didn't want to do that. So I did those two changes, and then this is the meat of it. I found out that for this lens, if I do that, the primary functional sagittal depth is 4,060 microns, okay? And this is a very important number to know. And the reason is, this is where your lens lands. If you notice, this is a 16 millimeter lens diameter, but it doesn't land on the tippy toe. It doesn't land on the outer edge. It lands at 13.9 millimeters, okay? And so that is what the primary functional sagittal depth of the lens is. And whatever lens, whatever brand you're using, you really need this number, because this tells you, how much clearance that lens is going to give you. And there's a trend and there's a movement, if you will, to take Scleral lens terminology and make it uniform, because all the different lens manufacturers have different terms for all these things, and it's very difficult to transition from one brand to the next because there's nothing in common. And so this is another excellent paper, just not even a year old, for some really sharp people, and it's just an effort to define all these terms. So I urge you to read that. All right, so I made the changes. The guy looks pretty good. His clearance is good. I'm sure most of you by now are fitting Scleral lenses, so you know that you always want to compare the clearance, the fluid reservoir, to the thickness of the lens. You want to do that. You see the cornea, of course, in the lens. Okay, so yay, looks pretty good. Looks like a pretty good looking lens, and the guy's pretty happy. All right, so this is what we ended up with. Just increase that toricity in the haptic, get him a little bit of more clearance in that left eye. Another thing, here's another tip, is you notice that in the right eye he has a diopter 75 of toricity, or in his RX astigmatism, cylinder correction, and 125 in the left. This particular gentleman needs that, but in fitting lenses and diagnostic lens, if on my overrefraction I get 125 or less, I do not order toricity, that is cylinder in the RX, until I fit that lens, because sometimes that so-called residual cylinder is due to the lens not being centered. So before you start adding cylinder to your RX, you want to make sure that the lens is centered, and a toric haptic is really going to help stabilize that lens. So that's important. All right, so let's change gears. I hope that makes sense and gives you some fitting tips. So here's a quiz question for you. Keratoconus or pellucid marginal degeneration, right? This is a very interesting thing. I'm sure a lot of you are probably still being taught that this is the kissing doves, or the crab claw. But that is not the definition of pellucid marginal degeneration. And I didn't realize this myself until a few years ago when I was working with the case, and I was calling it that. And a couple of friends of mine said, hey, Tom, that's not pellucid. So I thought, really? So here's a little shameless self-promotion. Christine Sent, who's a good friend of mine, who's one of the people that kind of called me out on that. We published a paper last year, this is Spectrum, about what is PMD, what is pellucid versus keratoconus. And it really turns out that the two are quite different, and true pellucid is very rare, actually. Michael Bellin is an ophthalmologist in Arizona. He's one of the leading cornea specialists, really probably in the world. And this is out of a manual where that asymmetric curvature pattern can occur in a normal cornea. When the apex of the cornea, when the line of sight, which we know never goes to the apex, and your measurement axis don't line up. When these things don't line up, you're going to get this kissing dove or crab claw appearance. So it really is misdiagnosed, and it's misdiagnosed because placido disc imaging doesn't get out that far, doesn't reach out to the peripheral, and you're not looking at thinning. Okay, so that's it. And Michael Bellin's a really sharp guy. I urge you to read some of his papers. He has a lot of webinars on this. Very, very sharp. So with Scheimpflug type image, or if you just have applanation pachymetry, however you want to do it, a band of thinning inferior, across the inferior limbus, that is what pellucid is. And in all the many patients that I've fit, I only have 2 in my practice that really have pellucid, and this is one of them. 80 something year old retired physician. So this is the same map of what we just saw, but look at the thinning, and you can see it's a low cone, and most of these things that look like pellucid are simply low cones. So I want to bring that to your attention. Certainly was brought to mind, and that's what I was taught. So anyway, here we go. That's both of his eyes there. Okay. All right, so let's talk about some other ectasias that you may want to use scleral lenses for. All right, here's a 39-year-old woman, and she was referred for scleral lenses because she had ectasia resulted from a prior thing. Let me see, there's a little click here. Okay. Anyway, she has dry eye disease. She lives down on the Texas coast. It's very, very windy environment. She happens to be a smoker, so she has a lot of strikes against her, but she wanted contacts and she wanted something she could see well. Again, here's an axial map, and you can see where that distortion is. Okay, but again, I've urged you to think about elevation, and you can see here on our elevation map that area, down at 5 o'clock really falls away and gets quite thin in that area. And if you look at her prescription, she can see, 20/20, she's correctable in 20/20, but all that cylinder in her left eye and also oblique. So normal cornea, but again, ectatic. So we took her corneal sagittal mean height, and we've got the values you see there, and then HVID. HVID is very, very important. You always want to know the horizontal visible iris diameter in anybody that you fit. That's very important in selecting your first lens. So let's use some of the latest technologies here, scleral profilometry, and we can call this fitting by the numbers, if you will. There's several of these units out, and this is one, and we can use it to illustrate our case. So this is where we're finding that ectasia of the sclera. Where are the high points? Where's the low points? What's that spiral of Talot doing? Okay. All right. So first step, HVID. And in this particular instrument, it's called horizontal light to white, and it's 11.6 millimeters. And that's a very average cornea. That's a very, very average cornea. Therefore, I'm going to go to my trial lens set, and I'm going to pick a lens of an average overall diameter, which just happens to be 15.6. And this is where I use the profilometry data here. I know from the manufacturer that this 15.6 millimeter lens actually lands at 13.6. So I want to know, well, how high is the cornea from a chord of 13.6? And the midpoint is, you see, 3355 microns. That's the mean sag. But that's how high the cornea is, and I'm fitting a scleral lens, which I want to clear. So I'm going to put in a fudge factor of 300 microns, because it's a well-known, it's a rule of thumb that scleral lenses will drop about 100 microns. Whatever you put on, you're going to lose 100 microns with wear. So there's my fudge factor. So the clearance that I need from my lens is 3,655 microns. That's what I need to clear and have a little cushion there. All right. So I'm going to go back to this little calculator. As I said, this HVID is quite normal. It's, so I'm gonna go to my fit set, and in this particular fit set, 4,600 is kind of normal. All right. So I want to answer, what is the primary functional sagittal depth if I pick a 4,600? So I'm going to hit the calculate, and the calculators tell me that it's 3820. So that's 165 microns too much. So if I put this lens on my patient, I'm going to have over 400 microns of clearance, 450. So I don't want that. Okay, so what am I going to do? So I'm going to go back. I'm going to change it to 4,500. All right. I did apply an over refraction that I had, and that's what I get. Okay, so by dropping it 150, then I can't come right back down to where I want to be with that 3655, I think. So that's the lens that I'm going to select for this particular patient, and I do it by some hard data. Okay. So ordered the lenses, I ordered them and I dispensed them, and they were really comfortable. They were really good. Again, you can see that they're centered. And the way you can tell they're centered is that you don't have a prismatic prism appearance to your fluid reservoir. You see that that's pretty parallel, and it's parallel all the way out, going towards the limbus. So that's another way you can tell about decentration, is not only to look at the overall lens, the periphery, but look at the fluid reservoir pattern. So I've centered this lens pretty well. So everything's looking good. She sees great. She's comfortable, windy environment, wears them all day. Everything's great. Yes, but, right? There's always a but, okay? And as I said, we're right outside of Houston, and astronauts are a big part of us. We were very proud of NASA. And in fact, as an aside, my next door neighbor's oldest daughter was just picked last year for the Mars program. So I actually have a neighbor that's an astronaut. So that's pretty exciting. But that's not the kind of problem we have here. What do we have there? We got a pinguecula, don't we? And living in Texas, and with the sunlight, everybody has pingueculas. I mean, it's just kind of universal. All right, so her wearing time is great. They feel good. They're not dry. But my eyes get red. That's what she said. She said, yeah, I really like the lenses, but gee, my eyes get really, really red. People ask me what's wrong with me, and I don't like the redness. And again, we've talked about how you have to take the lenses off, and you have to, stain, and it's real apparent, that I'm digging into that. I'm digging into that pinguecula, which we don't want to do. So what we used to do is we used to notch. Yeah. So when we had this kind of thing, like this guy's got a big old tube shunt here, so we certainly don't want to impact. So again, different patient. But just to illustrate, we used to have to just notch. And if you look here, there's two notches. There's a notch here and there's a notch here. And for many years, that's what we did. We mark it up. We kind of draw it. We call the lab and say, make it this big, and that's what they did. But the problem with that is a notch is just a cutout. It's just taking a lens that's spherical and just cutting it out. And so you get this big thick edge, you get bubbles underneath it, and it may be uncomfortable. The lid may be hitting it when it's superior like this. So notching is not the preferred. In fact, if you look down here, you can see some bubbles. So he's got some bubbles here. So anyway. So what do we do now? Well, what we do now is we have a calculator, right? And so what we do with this, we put in the lens that we got, and it does have a toric haptic as we've illustrated. And so we got to tell the calculator where the haptic is. Okay, so we've rotated around and paste it there, and then we say, okay, where do I want my controlled peripheral recess? And there's a difference. This is not a notch, and I'll tell you the difference there. But we want it here. We want it to be 0.3 millimeters deep, and the recess chord, which is the width, we want it to be about 3 millimeters in wide. Okay, and we could, if we wanted a second one, if we had bilateral pingueculi, then we could get another one as well. The difference between a controlled peripheral recess, and you can print this out and keep it and put it in your EHR, and this is a record of what we've done. And you can see here, it fits beautifully. And here's my little marking. Here's the flat haptic that you saw, the flat axis of the haptic that was you saw in the illustration. And now we're getting over that. The difference between this and a notch is this is a uniform thickness all around the edge. This is just like taking the edge and bending it over this, if you will. We're not cutting into the body of the lens. This edge is not thicker anywhere along. It just, it's retreated, as you see. We made it 3 millimeters wide and 0.3 millimeters deep. We've pulled it back, but the edge configuration is uniform all the way around the lens. And the fact that it is into the laser program, this lens can be replicated exactly time after time in case of breakage or a spare pair or something. So we've come a long way from just taking our little Dremel tool and cutting it out. Okay, we actually, and this is not unusual. She wanted Scleral lens for the right eye. Even the right eye was normal. You recall that this is an ectasia, the left eye. The lenses were so good, she got one in the other eye, and she probably had a bigger pinguecula here. And again, you can see how it goes nicely over it. It's not red. It's not congested. So this is really the way to go on that. Let's talk about, I got just a couple minutes left, talk about the landing zone or the haptic. How are we going to deal with that? We talked about how ectatic it is. Some designs use angles, degrees of slope, if you will, like those of you who ski, right? Green runs, blue runs, black runs, steeper it is, harder it is. Some others use sagittal height, that actually how far down are we going on the eyeball to land, right? It just depends on the manufacturer, okay? But, the steeper the angle, the greater the depth, right? So an angle of 44 degrees, a steeper angle is going to be a higher sagittal depth than something that's 35 degrees. And you can see in this case, that's 200 microns different. And so there's your toricity, in difference in toricity, even in one meridian. So think about slope, think about how this is really quite an early, from an early paper by Randy Kojima and Pat Caroline at Pacific, where they looked at the average angles. And this kind of goes back to the spiral of Tillot, as you can see, where the nasal is not as steep, not as curved, temporal's more, and so forth. So the thing is, these are the angles that change in relationship to the extraocular muscles and distance from the limbus. The other thing that's important to note is this is straight. These angles are very, very straight. They're linear. We're used to fitting curves. We think of the cornea being a curve and globus and the cone. But when you get past the limbus onto the sclera, it's straight. And so that's the way you want to keep that in mind when you're designing the haptic. And you can see here 2 examples where this haptic, or the landing zone, is absolutely straight. In the top picture, you can see how it's landing inferiorly. In the nasal limbus, you can see this is sclera, or I'm sorry, this is cornea, and this is transitioning into the limbus, and you can see how linear that is. It's like you want to land a plane slowly and smoothly. You don't want to come down from 40,000 feet and drop and land. You want to come in on a glide path, if you will, a slope. And this is the way, hopefully, you can design your lenses. All right, I don't want to run over. Thank you for listening. Keep an open mind. We don't know everything. all of us are learning together. The smartest people I know admit there's a lot to learn. So we don't know everything. Don't let that be a barrier to your progress in your career. And congratulations to all the graduates. And I wish you all the best.